Hi, there's a silent pandemic of diabetes taking place, and with it, diabetic peripheral neuropathy is on the rise. Join me as we take a look at the causes, prevention, and management of this phenomenon. There is a pandemic of diabetes and obesity sweeping across the world right now, and the International Diabetes Federation estimates that about 425 million people suffer from diabetes at this time, making it one of the largest global pandemics of the 21st century. As the incidence of diabetes rises, so does the incidence of diabetic foot syndrome or disease. Diabetic foot syndrome or disease consists of many conditions. Two of the main ones are diabetic peripheral neuropathy and diabetic peripheral arterial disease, which can lead to ulceration. And most cases of diabetic amputation are preceded by ulceration. Diabetic neuropathy is a unique degenerative disorder of the peripheral nervous system that targets those nerve cells that feel sensations, as well as the nerve cells that control the involuntary functions and the activity of internal organs, and later, to a lesser extent, those nerve cells that control the muscles. Diabetic peripheral neuropathy is a loss of sensation that begins in the toes and that over time may lead to pain and disability. Over time, about 50% of diabetics develop diabetic peripheral neuropathy. The mechanisms underlying neuropathy in type 1 and type 2 diabetes remain unknown. Diabetic peripheral neuropathy is usually symmetric and manifests in a stocking-glove distribution whereby the hands and the lower extremities are commonly affected. There are, however, other types of neuropathies that come from diabetes, and these include neuropathies such as cardiac neuropathies, gastrointestinal dysmotility, diabetic bladder dysfunction, or erectile dysfunction. Single nerve neuropathies, although less common, involve individual peripheral nerve neuropathies, or even less commonly, radiculopathies, which are neuropathies of the nerve root. The incidence of neuropathy is higher in patients with type 2 diabetes mellitus, but the prevalence of neuropathy is similar in the two groups. The duration of diabetes and the hemoglobin A1C level are major predictors of diabetic peripheral neuropathy. Obesity is also commonly found in patients with peripheral neuropathy and may be an independent risk factor. High triglyceride levels, high blood pressure, abdominal obesity, and low HDLs are consistently associated with neuropathy in patients with type 2 diabetes mellitus. Other risk factors for diabetic peripheral neuropathy include smoking, alcohol abuse, increased height or advanced age. Several genes have been linked to diabetic peripheral neuropathy. Progressive diabetic peripheral neuropathy involves a retraction or a dying back of the nerve filaments that run in the extremities, in which the cell body is spared. Experimental evidence, however, shows that the whole neuron is usually affected. Diabetic neuropathy is not considered a disease of the nerve sheaths, but the nerve sheath cells, called Schwann cells, are targeted by high blood glucose levels, and more severe diabetic neuropathy includes the destruction of these cells. High glucose and lipid levels damage the nerves in diabetic peripheral neuropathy. Inadequate flow of blood to the nerves due to damage to the tiny blood vessels to supply the nerves with blood also leads to further damage. Diabetes has been shown to decrease the formation of new vessels by decreasing the formation of insulin growth factor as well as other growth factors. Insulin itself has been shown to directly stimulate the growth of peripheral nerves. Studies have shown insulin receptors on nerves carrying sensory impulses and the reversal of diabetic neuropathy in patients given insulin independent of their glucose levels. Despite these findings, correcting high blood sugars using insulin has little effect on diabetic neuropathy in patients with type 2 diabetes mellitus. By contrast, achieving normal blood sugar levels using insulin provides a significant therapeutic value to patients with type 1 diabetes mellitus and diabetic neuropathy. This paradox may be due to the development of insulin resistance in the neurons in those people who suffer from type 2 diabetes mellitus. 30 to 50% of patients with neuropathy develop pain, which most commonly takes the form of spontaneous burning of the feet. Patients can also report pain or tingling with normally harmless stimuli such as the stroke of a brush. These symptoms are often accompanied by loss of sensation, and patients complain that their feet are constantly painful and yet they cannot feel. Female sex is a risk factor for painful diabetic neuropathy. In addition, although pain can be seen in all stages of diabetic neuropathy, it is more frequent in patients with more severe diabetic neuropathy. Other factors associated with painful diabetic neuropathy include poor blood sugar control, kidney disease, and obesity. Damaged nerves in patients with neuropathy can develop hyperexcitability and fire even when they are not stimulated. We know a patient has diabetic peripheral neuropathy when they have symptoms of peripheral nerve dysfunction and diabetes after all the diseases have been ruled out. The symptoms of diabetic peripheral neuropathy are numbness, tingling, pain, weakness, and unsteadiness, starting in the toes and moving up the leg and then to the fingers of the hands after the pain reaches the knees. On examination, patients with neuropathy show a loss of sensation to pinprick, temperature, mostly cold, vibration, position of the joints in a stocking glove distribution. Loss of ankle reflexes occurs early in diabetic neuropathy, and later weakness of small muscles in the foot develops. Major weakness on examination only develops in very advanced cases of diabetic neuropathy. The 10-gram monofilament test is a test in which the provider pricks the foot with a filament and that can be used to predict the development of diabetic neuropathy. The value of this monofilament test is that lower sensitivity predicts a high risk of ulceration. Vibration testing can also be used to demonstrate diabetic neuropathy. Evaluation of the deep tendon reflexes is also a good test for diabetic neuropathy, although not quite as good as the monofilament test or the vibration testing. Current data indicate that better glucose control has a large effect on the prevention of diabetic neuropathy in patients with type 1 diabetes mellitus, whereas the effect in patients with type 2 diabetes is much less, although it is still likely important. Studies have shown the potential for exercise to prevent neuropathy and to promote nerve regeneration. Other studies have shown significant improvements in neuropathy months after gastric bypass surgery was performed in patients with type 2 diabetes and peripheral neuropathy before the surgery. We, however, need further studies to determine the role of bariatric surgery and medical weight loss in preventing diabetic neuropathy. Current approaches to the treatment of diabetic neuropathy include improving blood glucose control, mainly in patients with type 1 diabetes, lifestyle modifications in patients with type 2 diabetes, and management of nerve pain. The best treatment for patients with type 2 diabetes and peripheral neuropathy includes lifestyle changes, more specifically diet and exercise, coupled with optimal cholesterol and blood pressure control. Tight blood sugar control with a hemoglobin A1C goal of less than 6 increases the death rate in patients with type 2 diabetes mellitus and has little effect on diabetic neuropathy. It is therefore not recommended as standard of care. Rather, good blood sugar control as part of a more personalized regimen is the optimum treatment of type 2 diabetes mellitus neuropathy. Alpha-lipoic acid has been shown to improve symptoms in diabetic peripheral neuropathy, and a dose of 600 milligrams a day seems to work best. Aldose reductase inhibitors such as apalerestat, marketed in Japan, is also used to treat diabetic peripheral neuropathy. Anticonvulsants and painkillers are used to treat the pain in diabetic peripheral neuropathy. Don't forget, it's absolutely important to discuss the management of any chronic illness with your primary care doctor. I hope you found this video useful. If you did, share and subscribe to the channel, and don't forget to hit the notification bell so that you can receive notification of new videos that come out. As always, thank you for watching.